So I've talked a lot about engaging patients and families, and I just want to stop here and give you a little bit more background information about why we think this is important and when it should be done. Next slide. So patient engagement and discharge is everything from engaging them to informing them, empowering them. In many cases, you have family members who are themselves serving in this role for either the first time or the 20th time. They need to be empowered with the information and the tools to be successful at their job. Are they even a capable family member in terms, are they available or are they a long distance caregiver? Are they equally frail to the person we're asking them to take care of? If you have a couple in their 80s, it's often hard to tell which one of them is the stronger player, and sometimes it's the patient and not the caregiver, and we have to figure out who's going to take on what responsibilities. How do you partner with them? What number are you giving them to call in case of an emergency or a question? Because if you don't give them a number, the number that they have ingrained in their mind is 911. And if you're not able to give them an alternative number to get a question answered, they are going to do what they think is in the best interest of their family member, and they're going to return them to the hospital or to an emergency department. And how do you support them going forward? Do you call and check up on them? Do you find out whether or not they're able to meet the discharge plan that you gave them? Have they filled the prescriptions? Do they need equipment delivered to their home? All of this becomes really very important. And on the next slide, I think it's important to realize that we've seen some change in the decision-making roles over time. So we used to think of the older generation as being one that wanted to have the doctors completely in charge of their treatment decisions. But as you can see from this 2012 slide, the times they are changing. If that generation was the one that we were looking toward as wanting to have their doctor completely in charge of treatment decisions, they seem to be mostly gone. So the doctor making decisions with input from patients is also low. But the doctor and patient making joint decisions becomes a very, very important part of this equation. 30% want joint decision making, but you have another 65% that are very interested in the patient having control of the decision with the physician having some level of input. So patients are no longer prepared to just wait for a decision in a treatment plan. They want to be active participants in their care, and that's something that I think over the last few years we've noticed CMS even changing to provide a code for physicians to have conversations with patients, and that started on January 1st of 2016. And I think it's going to be very important for physicians in particular to understand the decision-making preferences of their patients and families so that they can form the best partnership possible with patients and families to avoid readmissions and excess utilization. So on the next slide, I just want to show you a graphic about determining goals of care. So in the shared partnership that you have in the shared decision making, it's important to understand that the patient is aware of what has happened to them so far and getting an understanding from them if they understand what's happened, what are the next steps, what happens if things get worse, what is the trajectory for their treatments, how can they manage their symptoms, and what are some of their realistic goals. And I'll be very honest with you, not all providers are very good at having these conversations, and that's unfortunate. I think there is a great opportunity for providers to be learning early and often about this partnership. It is new. We long believed that particularly seniors wanted decisions made for them by their providers. Many of those seniors have since gone on to a better place, and the new generation of seniors coming up and persons younger than them want to participate in their own care, want to participate in their own decisions. Next slide. So creating a healthcare partnership is something that is really very important. And as of January 1 of this year, CMS is now paying for conversations between providers and family members and patients. These conversations, we were worried that, maybe patients would be knocking down the doors and messing up the schedules of providers because these aren't short conversations, and that this would be taking a lot of time for providers. That hasn't happened yet. And on the one hand, it's unfortunate that people are missing the chance to have conversations between providers and patients, but on the other hand, it's giving providers an opportunity to take this time to get better at having these conversations. And I would encourage you to look for resources within your own community, or you can consult us. We certainly have resources, as do other NRHI members, on teaching about having these conversations. You would not expect, if you were a surgeon, to be thrown into an OR to conduct surgery on a patient without having had some practice and some understanding of the basics. The same is true with these conversations. They are incredibly important to balancing provider goals and understanding and your expertise with the patient goals, so that we don't overprescribe or assume that a patient wants one course of treatment when in fact their goals take them down a different road. Next slide. There are plenty of ways to activate the patient and family. It is something that should happen pre-discharge, and by pre-discharge that often means pre-admission, so that you can start to engage the patient and family immediately. And then before the discharge, as soon as the patient is within your care, you start pre-discharge planning and education, and you follow up post-discharge. Because if you want to make sure that the care plan that you've developed is carried forward, sometimes that means that you have to have a touch point post-discharge as well. Next slide. There are many resources that you can use. I'm agnostic as to which of the resources you choose to use. Some of them are excellent. 5 Wishes is available in something like 60 languages. The pink in the middle is a POLST form for Pennsylvania. There are living wills that exist all over the place, and you can find one that is your practice is used to using, or your facility. And there are many ways that we can help patients and families prepare to be a part of their own care. Next slide. And very importantly, you can use technology to help keep you engaged with patients and their families, whether that's sending reminders, whether that's having them log into a particular website so that they can get additional patient education or information. You could be setting up a system to track their recovery progress and communicating between visits. If you don't hear from a patient that you were expecting to hear from for a long period of time, you may find them the next time in an emergency department or having had a hospital admission. And very often we hear from physicians the frustration that they had no idea that their patient was in an emergency department or in a hospital until weeks and weeks later. So this sort of communication can be very valuable to helping make sure that you can track your patients, for which you are now going to be held accountable for their outcomes, both in terms of quality and quantity of care.